Good morning, and for some of you, good evening. My name is Sten Vermund. I am a pediatrician and infectious disease epidemiologist, privileged to serve as Dean of the Yale School of Public Health. And I'll be introducing our panelists shortly. Let me just start out by saying that our goal today is to take a serious look at American healthcare, our workforce, our preparedness for emergency response, and also our biopharma industry, and take lessons learned from our COVID 20 months and see what our panelists think about the impact on any of these elements that are designed to prevent illness and care for those who are ill and maintain the economic integrity of our society in the face of threats. So when I say threats, one could speculate on everything from the anthrax bioterrorism back in just after 9/11. One could talk about climate change related health disasters that are becoming more frequent. One can talk about future pandemics. But just as an icebreaker, we might as well mention the Omicron variant. Many people remember the Greek myth about Cassandra, the woman who was punished by the gods by being able to predict the future, but no one could hear her, no one could understand her prediction. So she had the terrible knowledge of horrible future events, whereas others could not benefit from her knowledge. And many of us in public health feel that way because what have we been saying for decades? That we have the threat of pandemics, especially respiratory viral pandemics, similar to pandemic influenza, and sure enough, we've seen that in SARS, in MERS, in the novel coronavirus, and we've seen it in a variety of pandemic flu strains that have been far worse than standard flu strains per year. There are many other threats out there. We've also said that if we don't take provision of 11 to 12 billion doses of vaccine to the globe seriously, we are going to have new variants cropping up periodically. So sure enough, Delta variant, now Omicron variant, and we will see many other variants that emerge if we do not do what we were able to do for smallpox and polio and measles and any number of other diseases, which is vaccinate the world. We know we can do it. We need the political capital and the political will to support the WHO and Gavi and other groups to succeed in this effort. We even have an infrastructure called COVAX in which we can invest. So I do think that Omicron is a concern. We certainly see it as an example of how our entire panel may be misnamed. We call it post-COVID healthcare, whereas we're not in a post-COVID era. But I do think that with extensive vaccination coverage in the United States, we are likely to be blunting the severity of new variants. It's relatively straightforward for the pharma industry to produce boosters against specific variants, such as Omicron, should that be proven necessary. So I think high-income countries like ours are not going to be confronting Omicron as some sort of existential threat. I think we'll be able to handle it, and I think we'll be able to manage it much as we've managed the current Alpha and Delta variants as we go forward. So I'm not living in mortal fear of Omicron, but I think persons who have opted not to get vaccinated should be very afraid, because in our Yale New Haven Hospital, we've doubled the number of patients so that we had a month ago, and our whole Yale New Haven system, which is 5 hospitals, has doubled the number. And the persons who are seriously ill in these hospitals are those who are unvaccinated almost exclusively. We'll get a rare case of an individual who is vaccinated, but CDC is telling us that an 11-fold protection from hospitalization and 11-fold protection from death is expected with vaccination, and some estimates are even higher than that. So we have the tools to cope with the pandemic. Are we willing to deploy them? This will be a sub-theme, I think, for the whole morning discussion. Now, at this point, I would have introduced Dr. Marcella Nunez-Smith, my close colleague here at Yale, who is now spending a big chunk of her time with 3 separate jobs that she has in the federal government. And she was called away from this panel due to the concerns about the Omicron variant and various travel advisories as a member of the White House Task Force on COVID. So she is unable to join us and sends her regrets. We were commenting just before the call started that we sort of feel good that that Marcella has returned to her duties, because that's where we need her at this present moment, but we certainly are sorry to not have her on the panel. But let me introduce our other panelists. Bob Galvin is a physician and chief medical officer and senior partner of Blackstone Investment Firm. He also has an adjunct faculty position here at Yale. Bill Novelli is founder of the Georgetown Business for Impact and serves on the Georgetown faculty. I hope his background will come out in the discussion, because Bill has an extraordinary career. Josh Steiner is chair of Castleton Commodities and serves as senior advisor at Bloomberg Limited Partnership, which handles a lot of the software elements of Bloomberg Inc. And Josh is a member of the Yale Corporation. So he, I think, would be my boss's boss's boss. And then we have Major General retired Irene Trowell-Harris. We've just celebrated Irene Trowell-Harris Day here in New Haven just 2 weeks ago. Our mayor honored Irene and her career and achievements by naming a day here in New Haven after her. She is the former director of the Department of Veterans Affairs Center for Women's Veterans, alongside many other distinguished elements of her career. And we are looking forward to the comments of all of our panelists. Finally, last but not least, is my colleague and co-chair of this panel, Dr. Lindy Go. Lindy is a partner with Tapestry Networks and leads their healthcare practice. She has a background both in basic cancer biology, for which she has a PhD, and also used to lead teams at Boston Consulting Group before joining Tapestry Networks. So welcome to our panelists. Dr. Go's special role will be to harvest questions from the Q&A. The chat is disabled, so if you have a question for our panelists or comment, please put it in the Q&A. And then when we have the opportunity, we will work those into the discussion. And Lindy's kindly agreed also to provide some summary after we're done with the panelists to capture key elements. So she's got a big job today. Thanks, Lindy. So let me go straight to the topic at hand. The COVID-19 pandemic dramatized elements of American medical, public health, and biopharmaceutical ecosystems. Some of these were inspiring, and some of them were woefully discouraging. So on the positive side was the unprecedented success of public and private partnerships for vaccine development, for accelerating regulatory review without compromising its depth or quality, and deployment of vaccines to stem the tide of the pandemic. So I'd like to ask Bill and Bob first, but any panelist can comment on anything. I'd like to ask them from your own experiences in the past 2 years, what were positive lessons learned, and how can we continue this momentum toward continued success in biopharma and application to urgent societal needs? So what lessons also have we learned about ensuring access to life-saving therapies? So how do we learn from the positive model and carry that going forward? So we'll turn it over to Bill first, then Bob, and anybody else on the panel.
Tim, thanks very much. You know, the positive side is well worth talking about, because we've seen that our science and technology enterprise is really innovative and really productive. And in many ways, I think industry really showed what it can do when the pressure's on, and it has been working at its best. And now, again, rising to the challenge of this new variant that you talked about earlier. But also, as you said, we're still in the midst of this pandemic. So continued innovation and cooperation is going to be critical. And of course, we keep running into political roadblocks that get in the way of technology. I think the private sector has been leading. The private sector has been leading, and the collaboration has not been perfect, but it's been productive and it's been effective with government and academia. The challenge now is that we need, I think, continued partnerships and even stronger cooperation to overcome COVID, but beyond that, to enhance the R&D ecosystem so that we can address other social and environmental problems. And I think worldwide health inequality, which you spoke of earlier, is definitely something in front of us, but also climate change, a really existential challenge to all of our societies.
Thanks,
Bob?
Bill. Bob, what are your thoughts? You're on mute, Bob, one of the most common sentences in the past 2 years.
Yes, thank you. I'm sorry. And so thank you for inviting me to be part of the panel. Great comments, Bill. We're focusing on the positive on this question. I know the next question has a lot of the inequity issues, but look, the headline to me of this pandemic, when the dust settles, is how science and vaccines saved us. You know, if you kind of do the math on a population adjusted basis from the 1918 Great Influenza pandemic, and in equivalent numbers, 1.8 million Americans died, where I think we're tragically at 800,000 now in the US, but we're still going to end up at a really probably half the number of deaths. And I think that's attributable to the vaccines. And I think that's just an enormous headline. And I think it shows the power of what happens, you know, when kind of the government and private sector get together. Look, the government's been helping fund R&D for a long time. This is nothing new. But what was fascinating this time was kind of through Warp Speed and other initiatives. It was partially the R&D, but, you know, to me, it was like the P&D, it was production and distribution that was new. And I think it was really very impressive. And so it's just kind of an enormous headline, and I think it's what's going to be remembered. I think the question is, how do you make this go forward? So let's assume we do get through this pandemic, and let's assume we saw, you know, what can happen with this kind of cooperation. And unfortunately, I'm not that sanguine about this collaboration being anything other than kind of an emergency situation. And it really, you know, it's so overused, the quote, but it's probably overused because it's so great, you know, attributed to Churchill, that Americans always do the right thing after they've tried everything else. And so when you kind of look at how complex the incentives are on the pharma side, when you look at the fight now that Moderna is in with the government about IP, when you look at how Pfizer didn't take government money, but did some purchasing and were really protected from a lot of market risk, it really worked well, but it's going to be difficult to transpose that to a peacetime or post-pandemic environment. I think we need to try. I think we, you know, do need some kind of 9/11 type bipartisan commission to look, because I think we can make incremental improvements. But again, I don't want to be kind of the pessimist of the group. But again, if you kind of go back and read John Barry's wonderful book, The Great Influenza, and you look at what were the lessons learned in 1918, and you look a decade later, you know, things regress to the mean. People have near-term biases. They have optimism biases. And so I think the challenge of how to incrementally make things better is in front of us, is in front of everyone on this call and us. And I'm hoping we can do something, but it's, you know, I wouldn't overcall how easy it's going to be to transpose it.
Thanks, Bob. Irene, you've had a distinguished career in the U.S. military, rising to among the highest ranks. And the U.S. military is always thought of as the logistics master. And when one is waging war, efficiency of decision making, efficiency of deployment of workforce, so to speak, is of the essence. Do you have any thoughts about positive messages that come to the American health system from COVID?
I think I really agree with the previous presenters, but the point about working together, bringing together all professions and committees to deal with this. And I think if you look at the military, it plans for all kinds of missions. Once in a while, they get surprised, but it's a plan. But keep in mind that when there was a problem in New York, the ship was sent in. If they needed someone to assist with vaccinations, they call up the National Guard or the other Reserve Corps. So there are plans, but we have to keep in mind that there are unprecedented events that happen that we have no control over. But we're going to use our powers of working together across all professional lines to deal with those kinds of things. So, you know, again, we don't know what's going to come next, but I think based on our experience, we are ready to respond the best that we can. And having somebody in the White House and having all these experts around, we will be successful.
Well, that is a positive note. Josh, you have participated in public-private partnerships in non-healthcare contexts. What are your thoughts?
Well, first of all, thank you for inviting me, and I thank the Yale School of Public Health for doing this. And just as a member of the Yale community, to thank my fellow panelists and the participants who are coming. I have to correct you, Stan. The notion that any academic has a boss is completely contrary to everything I know about how universities are run. So there'd be a lot of college presidents who are a lot happier if they actually thought they had people who work for them. My experience is the contrary. I'll give a couple of reactions. First, Irene, to your point, you know, that's that great line by Mike Tyson, which is everyone has a plan until I hit them in the nose. And I think what we've learned is that we had okay plans and then we got hit in the nose and our plans weren't quite as robust as we thought. And to your point, Irene, the military, generally speaking, has decades of contingency planning. And as it turns out, most of our institutions haven't learned from the lessons of the military. There are at least two acts, as you know, which actually require the military to have war materials pre-positioned in Diego Garcia and around the world. And that's been very much built into it. And all the war planning and scenario planning that the military does is something which is completely foreign to the civilian government. So I think that is an important element of what lessons we can draw. without obviously making the mistake that we did on the war on drugs and thinking that everything should have the word war attached to it before we take it on. The second point I'd like to make quickly is just to your point, Bob, about science saving the day. And obviously you are correct. And the flu epidemic is a good example of how important that science work was. I think we have also, though, highlighted a problem, which is well aware, is that there's been this tradition that if the science was sufficient, scientists could work on the science and the marketing and selling of the science would take care of itself. I think one of the lessons that we do need to draw from this is that, in fact, it is ineffective for the scientific community to operate in isolation. And this is a little bit your point, I mean, I think about collaboration from the people science is trying to serve. And I think higher education generally, as we've seen around the country, which has been subject to defunding over the last 10 years, is emblematic of the same problem. And I think one of the very powerful lessons is that if we're going to be successful in working through future problems, we have to figure out a way where the scientific community is more embedded into society, is more trained to understand how most people think about these issues, learns the vocabulary, and spends not a disproportionate amount of their time, but a portion of their time actually thinking about how the benefits of science can be promulgated in society as a whole.
It's a very interesting point, Josh. I think I'll get out of my moderator mode and just join the panel for a moment. It was about 5 years ago that I participated in a National Academy of Sciences, Engineering and Medicine panel reviewing science and technology engineering for the State Department. And it was a report that was an update of a report from 20 years ago on the same topic. And what we learned in our interviews and our deep dive was that there is a very vibrant STEM environment in our Foreign Service, with scientists hired by the State Department, deployed all around the world. It might be a geologist in Kazakhstan, it might be a public health expert in Zambia, and on and on. But they will never rise to the rank of ambassador. They will never have the same career path. There's a glass ceiling for the STEM track because they're just not seen in the same breath as the folks who have the political and economic backgrounds that are seen as the essential ambassadors. Now, maybe that's right or wrong, but it does come to the point where STEM is de-emphasized in that particular sphere. And one could argue who has the greatest logistics planning and the greatest flexibility, the US military or the CDC? And which is the most subject to political pressure, the military or the CDC? And we could discuss something like that. But I think the nature of my question, I'm hinting to you, not too subtly, that perhaps the CDC is not particularly empowered, even if it is waging war on pandemics. And even if it does contingency planning, as it did in 2017, extensive report on pandemic influenza prevention and what should be done about this. And very few of the CDC recommendations from 2017 were operationalized, all of which would have been highly beneficial facing the 2020 COVID pandemic in the United States. So I think these are lessons that we might want to learn a little bit on the negative side, which brings me to my next question. So we did have a relatively poor capacity on behalf of our state and local health departments, even our federal response from the CDC. And it's manifested, for example, in what a poor job we did protecting some of our most vulnerable. So it isn't rocket science to say that in a pandemic respiratory threat, such as influenza, or in this case, coronavirus, the elderly will be the most susceptible. But we didn't have contingency plans for nursing homes and assisted living facilities to ensure that workers in these homes or visitors in these homes or patients themselves wouldn't be a nidus of transmission from home to home, from patient to patient. We also had the workers crowded into meatpacking plants and other frontline industries who suffered disproportionately from both infection and death in the early days of this pandemic. So I'm going to direct this one to Bill and Irene first. Can you comment on these negative lessons learned and your view of needed reforms? You know, the elder issues in particular. So Bill and then Irene.
You know, Sten, I think we can spend more time on the negative than the positive. I think there's been a lot of negative lessons, or we could say lessons we have not learned from this experience. And as you know so well, we've learned that America's public health system isn't really a system. It's a patchwork, it's underfunded, it's poorly organized, and it is subject to political pressures. We need to do something about the public health system in this country. Another thing is prevention. You know, health promotion and disease prevention, which ought to be our first line of defense, is not our first line of defense. And then CDC, which you talked about and which you mentioned, our national pride and joy. It too fell victim to political pressure. And once that trust is lost, it's really hard to regain it. And as you said, Sten, we did fail some of our most vulnerable populations. The ones you mentioned, the frail elderly, frontline workers. I think we really failed our clinicians. I have a friend who put down her work and volunteered as an emergency doc in New York's first COVID surge. And she saw multiple deaths and she's still getting over that. She's still recovering from that experience. And this is continuing today in your hospitals and across the country. At a recent meeting that I attended at the National Academy of Medicine, it was said that we failed psychology, we failed sociology, we failed communication, and above all, we failed caring about each other. And somebody said, on this pandemic, we get an F as a nation. You know, there's a lot of medical mistrust out there. It's always been there among people of color, certainly African Americans. But there's some indication now that medical mistrust is growing among older people as well. They just see the medical system as a big commercial enterprise. And we need increased federal support for science and technology. And we need enhanced science and technology leadership and coordination at the highest levels of our government. And right now, we don't have that.
Frank words. Thank you. Irene, what are your thoughts?
Yes, I think since this was an unprecedented epidemic, CDC, health departments, federal government, they were not prepared to really deal with it. But keep in mind also, it took some time to call together the professionals, get together with some committees, collect some data, and then make a decision. It's not an excuse, but when there are unknowns out there, we need some data in order to make the first step. And I just want to mention that the second thing, which has been brought up already, the pandemic really did bring up the negative idea that we really need to address healthcare in relation to equity, diversity, and inclusion. Keep in mind with early on with the nursing homes, there was not adequate personal protective equipment for the patients or the nurses. Many people advocated for that. Dr. Ernest Grant, the president of the American Nurses Association, went to the White House and discussed the problems and the diversity out there. And he did get some assistance with that. But like you mentioned, we really were not prepared to take care of the most vulnerable, the elderly, those in assisted living, frontline workers, even our healthcare employees. They did not have the proper masks or the gowns, et cetera, initially. This was taken care of, later on though. But I like to really focus on what can we do to help and change this now though? What reforms do we really need to do now? We need to really address equity in personal protective equipment. That distribution should be available to everybody. Nursing homes, the staff, those frontline workers in the meat packet, everywhere. If we don't take care of them, who is going to take care of us? We must take care of those who are taking care of us. The second thing is we need to immediately classify the elderly, frontline workers, those meat packers workers as priorities and get them the equipment they need so they can take care of others. The third thing we need to do is look at workers' compensation presumption for healthcare workers and others. Right now, I don't think there's many states out there that are looking at compensation for those who are suffering from long-term effects of COVID-19. There's been a lot of questions raised about this, but we must again look at protection for the long-term impact of the COVID-19. And again, like I said, we really need to address healthcare as far as being equitable for minorities, for women, for everybody. So again, I'd really like to highlight what we can do, to take care of the situation now. Lessons learned, we really need to take care, we really need that technology. There were some areas also, I think it might have been mentioned already, where the technology didn't work as well as we had hoped it would. So we really got to look at that technology part of it and take care of our, people. So I'm just so pleased that we're discussing this now, but we really need to take the advice, the recommendations today. Let's put them in action by, again, calling everybody together, getting together with our political comrades out there to take the action now. Thank you. That was a wonderful question.
Hey,
And I
Stan,
just go ahead, Bob.
Go ahead, Bob.
Lindy, were you going to say something?
I was just going to, there were a couple of questions from the audience, so I wanted to raise, and I think they get into that point of medical mistrust and equity issues. So there's a question about what can we do, as Irene kind of did the very strong call to action. What can we do now moving forward to really address these issues? And one of the questions asked, what can public health do in terms of improving communication to the public? How do you translate public health findings? So Sten, if you'd like to be part of the panel and comment on that as a head of a school of public health, or Bob, that would be great. And then another point, just a separate question on how do you get acceptance of vaccinations more broadly? Because there is this resistance, not just in parts of the US, but around the world to address that. So I think that gets into the mistrust issues that both Irene and Bill brought up.
Stan, go ahead.
Well, I do think this has been a clarion call for the need for improving STEM education in K through 12, not to mention colleges. The ignorance level of many people in society on basic principles of biology and immunology is profound. It's not hard to understand how a vaccine works, and yet many people don't have a clue. It's also a clarion call for the need for people such as myself in academia, academic public health, medicine, nursing, and allied health professions to spend at least as much time communicating with the general public, the communities in which we work, and policymakers, including elected officials, as we do communicating to our peers. The culture in academia is very much you're promoted based on your peer publications, the scientific papers you write so that other scientists read. And yet this does not trickle down to knowledge in the community. You have to do that separately. You have to communicate in much more accessible ways. And at Yale School of Public Health, we've hired an MD, MPH to teach our students how to write for popular audiences. James Hamblin from the Atlantic is a lecturer in our school. We've hired Neil Baer, who's also an MD, MPH, who has spent his career as a Hollywood scriptwriter, particularly for television, ER, and a number of other well-known programs in which he's made it his mission to communicate complex health topics through drama, through television drama. And so we're making efforts to open up for our students the ability to write a coherent op-ed piece, to provide information to legislators, to give a talk at a high school or a church or any number of community-based organizations as a fundamental part of our public health training. And you might say, well, haven't you been doing that all along? And I'll say to some extent, but this has been a wake-up call that we're not doing it well enough, and we have to redouble our efforts. Now, I could talk all day about this, but I want to hear what Bob has to say.
Yeah, thanks, Sten. So I agree with all of that kind of from a top down. Let me share some experiences I had. So what I've been doing during the pandemic as a chief medical officer is advising actually 150 different companies that are part of the Blackstone portfolio about what to do about COVID. So this isn't going to get to the equity issue. These are employed people. It's a specific population. But what was most remarkable about this is there was nowhere to turn for any of these companies. And by the way, Bill, I think the system, F is a tough grade. And I think if you're on an absolute scale, it's probably correct. But if you're grading on a curve, what individual companies and institutions did was actually pretty remarkable. It's literally that every one of these institutions were their own kind of like CDC. They created their own policies. It was really quite remarkable. I was impressed to the degree to which the CEOs of these companies, it brought out how much they cared about their employees. They needed them to be there to do the work. And it was fascinating. But what was remarkable was public health in the way they needed them in their local communities was invisible. And they didn't even know the word public could go before the word health. And that is how we funded healthcare in this country. And so I think it is important to write op-ed pieces. And I think it's important to send everything what you said. But I think one thing we've learned is people get a lot of their trust from the community they live in, the people they interact with, their local community. It's just part of our structure. One of our CEOs basically said, a centralized, decentralized liberal democracy is the worst political structure to handle a pandemic. And I think that showed true, but that means that so much happens locally. So I would have to tell people, look, here's how you find your local public health agency. They would call, and mostly they got voicemail and didn't get called back. And I think that was because we've so underinvested in local public health. And I think that's something we can do something about, where actually a bunch of money has already gone there through kind of the one of the emergency acts. Like, sure, it's being battered back and forth in the Build Back Better bill. But to me, that local presence, I have an issue. What do? I can count on this person. And Sten, to the degree that those communicators can be in the churches and the schools and where people go, that's where we have found, again, with our companies, that we get the most resonance. And so that is a money issue. That is a funding issue. And we need to have, I don't know if it's 50 or $60 billion over the next 10 years. I'm not sure what the right number is, but it's far more than we're putting to it. And that was just a very interesting lesson, again, from the private sector and this communication and who do you trust?
Just may I add one quick point to that, because I totally agree with you, Bob, and that's been our experience as well, that people are turning to their employers or their other forms of local community for guidance, and members of the clergy and CEOs and presidents of organizations have had to fill that void. And I think you're absolutely right about the need and the fact that then effectively they should be supported more. Since we're talking about public health, Sten, just picking up on one thing you said, since I assume a number of the participants actually come from the field of public health, I would caution all of us as we're thinking about just taking vaccines as an example. And I'm always loath to over apply business examples to other problems. So with that caveat, when people have a product, in this case, the product is vaccine, the temptation is to say, if you just understood my product better, you would take it, you would like it, you would buy it. And I just need to explain to you the science of the vaccine and assume that by explaining the science and explaining my product better, in this case, a vaccine, people are going to be more willing to take it and to effectively purchase or buy into what you're producing. I think that is actually proven not to be true. And so I don't actually think, although it would certainly help, the problem is that we don't do enough STEM science in the United States. That is true that we don't, and it would undoubtedly help if we did more of it. I think what we need to recognize is there are important parts of society who are making this decision using a different set of criteria than the people on this call might be doing it. They are very focused on agency in their lives. They're very focused on historical injustice that has taken place. They've been abused by the healthcare system. They have powerful examples, Bill, to your point, of where the healthcare system is actually not aligned with their best interest. If we want to talk about vaccines as an example, and we don't recognize that this isn't just about the science of a vaccine, and we don't find the vocabulary, and we don't use language and talk in story form that help people understand that we respect the legacy of the mistakes this country has made in the past, and the fact that people don't have the agency, that they have been abused by the system in the past, I think we're going to be unsuccessful. And an over-reliance on just talking about the validity of, in this case, the vaccine or the product, I think will lead us to have further failings in the future.
Lindy, if I can add to what Josh and Bob just said, I agree with them so much. The idea of communication right now is something that's being very carefully studied. There are probably 5 or 6 or 7 different segments of the population who, as Sten said earlier, is not getting the vaccination, is not doing the follow-up that we hope they will do. But they're all different segments. And there are African Americans who remember all the way back to Tuskegee, and they know that they're not getting proper care in our health system. There are other people who are low income, they don't have time, they don't know what it costs. There are other people who do have political objections to vaccinations. And there's probably 3 or 4 other segments. And what underlies all this is that the American public does not really understand or support science. And we need to start there with STEM and with other kinds of things. I saw a study recently that was really interesting. The first question asked of the public was, what is it about science that you would like to know? And you're not going to believe this, but the first question was, are there really space aliens? This is where the public is. We don't understand this. We have to do a way better job of communication if we're going to make any progress. And as Josh said, it's not just like, this is a great scientific product, buy it. That's not where we are.
I would like to make just one point. We discovered early on that quite a few elderly people live alone. Many do not have computers, yet they kept hearing messages on their radio and TV to sign up online or call in. When they call in, they were on hold for a long time, but many of them said, if I had a computer and knew how to work it, I would sign up online. So we need to think about that population out there that don't have the information, don't have the tools to respond to get the information. And again, this is probably one way where public health can help locate these people and give us some assistance. What happened in many of these cases, the religious institutions were able to buy computers for them, send a young person there to teach them how to use a computer. And many of them were very happy. And they were just so pleased with that. So again, we have to look at the technology, but also with people helping to educate them helping them learn how to work these electronic devices.
Thank you all. I do, what Josh said a moment ago resonated with me around the issue of mistrust and historic grievances. I believe that many vaccine hesitant persons were very concerned about being first in line, being guinea pigs and the like. And many of those persons have now gotten vaccinated with over 190 million Americans vaccinated, 5 or 6 billion doses given worldwide. I mean, we know these are among the safest and most effective vaccines ever developed in the history of humankind. And yet there are vaccine hostile or resistant persons who have dug in, and it may be as much as 12 to 15% of the US population that will not get a vaccine under almost any circumstance. And that is, as you suggest, Josh, not necessarily ignorance of science, but profound mistrust of government, of elites, mistrust of persons in political authority, in scientific authority, and is a much deeper and more profound concern. I'm almost reminded of J.D. Vance's book, Hillbilly Elegy, and many other books that are similar that are trying to get at fundamental and profound disenfranchisement from the American enterprise, which we certainly saw on January 6th of last year. But let's go to another question, and that is around health workforce. And we could even broaden it to be workforce in general. But given the stresses in the public health field, consequent to long-term underfunding of public health departments and schools and the like, these can apply to medicine, nursing, allied health professions as well, particularly for rural areas, and also superimpose the aging of the US population, which is a continuing tsunami of increased proportion of our population that are aged, very much thanks to prevention and healthcare progress. We are faced with the fiscal pressures of our health system. So in the face of greater need and historic neglect of especially the prevention side of our system, continued lack of insurance for a large proportion of our population. We also spend the most on our health care of any high-income country in the world. We're flirting with 19% of our gross national product spent on health, whereas I think number 2 is Switzerland at 14%, and many of our other high-income country partners in Europe, Japan, and elsewhere are spending close to half what we spend in terms of proportion. So this is the bind. What are we going to do to maximize our workforce and also workforce satisfaction? Irene alluded to this. Workforce satisfaction when patient flow rates are continuously sped up and clinicians feel less and less capable of meeting patient needs because of the pressures on them to see patients at a faster clip so that healthcare costs can be kept to a minimum and or profit margins to a maximum. So strategies for workforce needs, both in the short term and the long term in our health professions. So let me initially turn to Irene for this one, and then I want to hear what Bob thinks, and then the rest of the panel.
Yes, I will be addressing this mainly from the nursing perspective. So from the nursing perspective, we need to really classify the nursing shortage as a priority issue. And the second thing we need to do is for all employees, just not nurses though, is pay them a competitive salary with decent benefits. And the third part of that, we really need to address two other issues that impact the entire family and the entire workforce system. Address the mental health issues and to provide support to the healthcare workers, frontline, et cetera. We need the support for them, give them awards, recognize them. We need to do much, much more of that. But the second part of that is we must address the child care issues. This mainly impacts women, but it's a family issue. So basically, those three things we really need to address. And for the short term, from a nursing perspective, we really need to address that nursing shortage. As a matter of fact, Dr. Ernest Grant, the president of the American Association, proposed to the U.S. Department of Health and Human Services that they declare nursing, the nursing staff, as a national health crisis. That was done on September 1st, 2021. So we're waiting to follow up on that. We will not be able to increase the productivity, increase the bed numbers out there, or do any of this unless we fix the basic problem. And keep in mind, I'm not just talking about nurses. This is a support, pharmacy, the aides, housekeeping. This is everybody. If we don't fix this situation with staffing, we cannot open those new beds. So again, that is the first thing. The second thing is for the current employees, again, we got to pay them a competitive wage. And you look at the low income, the elderly, people working out there, we really got to take care of them. And the third part of that is we need a policy that's going to specifically address the mental health needs for all. This is the healthcare workers, those on the front line, and this is something very, very serious. So again, that is my short term. And long term, what I would suggest is that we really look at the educational funding and costs for all, medicine, nursing, the allied health and all, because again, we really need more healthcare workers. Keep in mind about the number that we have lost to illness and death. We need to replace those. Now that is compounded by the new nurses in school not being able to get clinical practice. So they can't just step in a lot of these positions out there without having some kind of, let's say, shadowing experience or supervision. So again, those things are really very important. And keep in mind also, we can call out the National Guard, the military to help out, but we should be able to fix our system. Again, my calling, everybody at the table, getting together, let's work on this together now. The key thing is we must take care of those who take care of us. That's my comment.
Well, I think everyone has guessed by now that not only are you a public health professional with your degree from our school, but you're a nurse, and you also have your doctorate in education. So you're covering all three areas, and I thank you for your comments. Bob, as a physician who now is at the interface between healthcare and the business world, what are your thoughts?
I am tempted to just say, after Irene's wonderful comments, agree with above. But let me add a twist or two. It really is a crisis right now in our hospitals. And one of the fascinating things we're all watching is the HHS mandate for vaccination and what that's going to do to a crisis already going on. That's not the topic you brought up. We're talking about broader policy here. But boy, no mistake what a crisis is today in hospitals in terms of the people that Irene was talking about And if Omicron does result in more hospitalizations, which I suspect it will, I don't think it's going to be any more virulent than Delta, like you, Sten. But just the numbers is, if it's more contagious and we have more cases, just percentage wise, we'll end up with more people in the hospital. So we have an immediate crisis at hand. But larger policy, you know, I've been on National Academy panels on workforce for a few decades. And so rather than talk about, you know, kind of licensure and state regulations, I just want to bring up another thing that I think is going to be an enduring legacy of the pandemic. And I think it impacts workforce, which is kind of this now kind of hitting the adoption curve of telehealth and using kind of digital ways to communicate with doctors. Again, Irene is right. If you don't have broadband, if you kind of don't have access to that, this isn't helpful to you. But it's really impressive that I think there's a 20 or 25% increase in the number of encounters that is going on between practitioners of any level and patients. It looks permanent. It's regressed a little bit, but it looks permanent. Some new regulations have come in by Medicare to enable it. And I think that opens up a different way of thinking about one part of the workforce in terms of what it could mean to the pressures. Clearly, if you are in the hospital, you know, a digital encounter with your doctor isn't going to help. On the other hand, kind of as AI blossoms, you know, we could have healthcare be more efficient inside hospitals, radiology, pathology, or issues. So I find kind of to the discussion of workforce, again, which I've been involved with for decades, which is so frustrating because we know what to do and Irene listed them. We have difficulty getting them done. There is a new technology, which tends to be the one thing that and regulations change healthcare. And that's this kind of this adoption curve, you know, of any innovation seems to have gotten a jolt. And we're on that S-shaped curve, and I think we're on the ascension. And how do we use that in a thoughtful way to address an aspect of this workforce? And that's kind of the thinking I've been doing about this, Tim.
So
Sten-
taking the urgency from Irene and the innovative suggestions from Bob, let's see what Bill and Josh have to say.
Well, Josh, if I can go next, what I was going to say is that when it comes to the healthcare workforce, I think there are many trends, but two of them that I want to mention are, first, Stan, you referred to this a little while ago, which is the aging of the American population. So what's happening is that the baby boomers have been relatively healthy, but now they're rapidly moving into old age. The oldest of the baby boomers turned 75 this year. And you know, what we're talking about here are people with advanced illness moving towards end of life care. And it could be a long trajectory. It could be 3 years, 5 years, 7 years if they have dementia, but it is happening. And the question is, how is the healthcare system going to deal with this? And how is it going to be affordable? And you know, the family caregivers are under enormous stress, and there are too few caregivers for this aging population. So that's one important trend that we've got to face up to, and we don't have answers. The other trend, I think, is the move from institutional to home care. And this is having an effect on the workforce as well. We're talking about policy, training, cost, payment models. I mentioned caregiving, patient satisfaction. It's going to continue well past COVID. And it's another trend that we've got to face up to.
Josh, final word on this question of workforce, costs of American healthcare, trends.
Final word is trust the experts, and I have nothing to add.
We'll get to you in a minute.
So Sten, just to add, I think there's a
Please.
question from the public on, you know, because we're talking in the context of the pandemic, you know, how can the pandemic support the viability of public health centric, businesses, I would say biopharma that could help solve this, problem of medical mistrust and access. Because we were talking about innovation, we're talking about the trends, we're talking about technology. So obviously technology also applies to the biopharma enterprise. So I don't know if anyone wants to comment on that.
Yeah, Stan, if I could, there's a
Please.
fascinating new startup by a woman who is the public health, the second in command in California, Charity Dean, who was highlighted on 60 Minutes, now has a company founded called the Public Health Company that's going to use AI and technology to better predict, to gather data, to scrape from different websites, to be a much better predictor of trends on a very local basis, and it's global. And so, and there are several other startups in this area that are getting funded by venture capital. And to the extent that the public is feeling a little bit yo-yoed, it's mass, not mass, it's a danger, it's not a danger, et cetera. A kind of better forecasting system and something that could be, really reliable and scalable, I think is an interesting idea. I don't think it's a solution to anything, but I think it's in response to what's new, and could technology do something to kind of help the public gain more trust. So it's just kind of an idea. I think it's an interesting company, and worth following. And by the way, I have no investment in it, and Blackstone doesn't either. That was a completely personal Yale comment on that one.
Let me just share a screen for those of you who are at your computers. This is from the US Census Bureau. It's something I use for teaching. And you can see that the aged population, adults 65 and over, which includes myself, will nearly double in from 2016 to 2060. And those statistics are highly reliable. In other words, very little is going to happen to change that trend. So we will actually have considerably more elderly adults in America than we have children, and we're going to cross that threshold somewhere around 2034. Just an interesting tidbit. All right, let's go back to our questions here. Was there any other question you wanted to work in, Lindy?
So I think the next question we're going to ask about where are we going forward
Yes.
in terms of infrastructure. Several people have asked, because Stan, you
Okay,
had
good.
noted 2017, the CDC had plans. Why aren't they implemented?
That's right.
Why don't we have a stronger centralized infrastructure? Or as
Yep.
I think in some previous conversations, Bob, you noted, why don't we have a 311, in government, with the structure and both at the federal, state, and at the community level. What's
Yep.
stopping us? So we've got the
So-
brains here, so hopefully, folks can answer that.
So that actually might be worth just touching on just before my last question. We did have a plan for manufacturing millions of N95 masks for the healthcare industry. And we actually let government contracts to how to do that expeditiously, but then we never manufactured them. We did the same for ventilators for assisted breathing in intensive care units, and a lower cost and high efficiency ventilator was developed, but then it didn't go into production. So those were investments the US government made to support research and development. But the next step to actually create a stockpile of manufactured items was not invested in. So we are not going from A to Z very well. We tend to go from A to N, and then we get bollocksed up at N until there's a crisis, and then we rush to get from N to Z. And this is true for vaccines as well. We had SARS vaccines for coronavirus, the spike protein of the coronavirus, in development in the mid about 2005, 2003, 2004 was the SARS epidemic, and then we had vaccines in development 2005, 2006. Funding was terminated because SARS went away. So nobody thought to continue development of those vaccines to anticipate MERS, the Middle Eastern respiratory syndrome, which emerged later in the decade, or the current crisis. And if we'd had those vaccines in the bottle, the time to modification and deployment would have been set records. We did the same thing with Ebola. We put a vaccine on the shelf for over a decade, from the Congo epidemic to the much worse West African epidemics. So the notion of looking ahead and making investments that somebody's going to say, that's a waste of money, there isn't any SARS anymore. But somebody else is going to say, but we know there are 200 coronaviruses in bats around the world. And we know from SARS and MERS that new coronaviruses will be infectious to humans, and therefore we're developing this vaccine. So somehow we are not making those kinds of decisions. Anybody else have a thought on that?
I'll just jump in for 1 second then, and again, being cautious about the analogies to the private sector. But if you think about Bob and his portfolio, Blackstone or their investment firm, there isn't the assumption that every one of their investments is going to be successful. They would like them to be successful, but what they're looking for on average is for them to provide really superior returns for their investors, which they've been obviously successful in doing. I don't think it's terribly surprising that we're in this situation. If you look at the history of government in the United States, one of the huge problems we used to have was corruption. And so how do you protect yourself against corruption? You put layers of bureaucracy in, and so that no individual has the ability to initiate a contract and receive payment back by herself, and you protect it through layers of bureaucracy. Similarly, we built in systems of oversight. And so, as you recall, we tried to have a program which subsidized solar energy in the United States. That program was unsuccessful. There was a lot of criticism of the waste that went into that subsidy, and the administration received a huge amount of oversight as a result of that, and people were very negative at it. Those two examples of where we have bureaucracy to protect against corruption, we have a very negative reaction to where there has been waste, are, I think, evident appropriately enough to a certain extent in the healthcare system as well. My understanding is in Europe, there are over 100 tests available for COVID, which have been approved. In the United States, there are roughly 10. Why is that? It's because our standards about what's efficacious and the risk associated with those are different than what exists in Europe. I think we need to have an honest dialogue about what we're trying to protect ourselves against. If we continue as Americans to be so deeply fearful of waste, it's very unlikely that we're going to make some of the investments then that you're describing. If we want to move with the speed with we were discussing in terms of addressing public health crises, we probably need to get comfortable with some elements of risk that have generally been antithetical to how we approach healthcare. And if we don't have an honest conversation about those underlying issues and come to a view about which of them is more important and whether we should prioritize one or the other, I think it's unlikely, in fact, that we're going to make progress on some of the things that you're mentioning.
Yes, Dan, I agree. Nice comments, Josh. And look, I wonder if one of the ideas circulating now is that you need to change the frame. And the frame needs to change from this as a health-related issue, where we've been frustrated, just as Josh said, where we have a cabinet secretary of Health and Human Services been unable, despite, kind of that elevated position, to kind of get our funding, to frame this as a security issue. Now, saying you should change the frame and getting it done is a different issue, but it's one novel way to approach it, because I think the country is more attuned to think about security as something that you go the rest of the alphabet, and probably you said A to N. Said I was thinking you were going to say A to M, so money, is kind of is what holds it back, and how do we get from N on? And so the one thing we do invest in consistently is military, because we look at the threat as so grave that you need a surge capacity, and it is sustaining. And so it's an idea that Scott Gottlieb, who many know, former FDA commissioner, kind of has been circulating this idea, wrote a book promulgating it. And it's a fresh way of thinking about it rather than saying, we're going to get a new surgeon general or we're going to get someone on the executive office of the White House. I wonder if approaching it from a health point of view does not fall prey to what you said earlier, Stan, that STEM people don't rise to the top politically. There's a ceiling, of health. And so if you change it to kind of a different kind of way of thinking about it, maybe it's a fresh approach, because it's going to take money. It's going to take the ability, to support the private sector, just like they did with vaccines, by the way, which is to say, I'm going to take away that market risk that you're not going to sell anything. And we're going to do that because it's so important. Whether that can be done through the health sector, I'm skeptical. Whether you can make it shift to something like security, where the country has a tradition of it, I think it's worth a discussion.
Yeah, I'm skeptical too. We all know that the private sector is better at thinking ahead than the public sector. And if you think in a democracy how we do think ahead, Congress is responsible for today, and they want to get elected tomorrow, not 5 years from now, not 10 years from now. So an example of the biggest problem that we have in this country today is obesity. The federal government is not thinking about how to control obesity. Nobody is thinking about obesity, and yet it contributes to COVID problems. It's a risk factor for so many things. This is an example of an area where, if we had the political will, as Sten said earlier, if we had the resolve, we could make progress, just as we made progress with tobacco. Obesity is a perfect example of not thinking ahead.
Last word on this one, Irene. You want to add anything?
No, I think I've said my piece on that one.
All right, that's fine.
Thank you.
So my last question, and we'll spend about just about 10 minutes so that we give Lindy a chance to really wrap up. We've had measurable successes in our contribution to innovation. Even here at Yale School of Public Health, we've contributed to novel diagnostics and modeling the pandemic and mitigating harms in schools and nursing homes, arts organizations, biologic discoveries, and on. And our sister schools of public health have done similar work, often with our medical schools and nursing schools. But funding is elusive for a pandemic. So-called emergency funding even arrives late. And organizations like the NIH have to take existing grants and find some legal way to supplement those grants, which may or may not get the money to the best coronavirus scientists in the world or the people who have the most innovative ideas. FEMA has resources to deploy in an emergency response. The US military was just discussed as a group in which contingencies are previously budgeted for, if you will, and their flexibility to deploy rapidly with friendly procurement options is available. Do any of you, and I'll turn to maybe Josh and Bob first, but do any of you have an idea of how the field of public health could have a model similar to FEMA or to the US military for rapid investment in pandemic response? Because I can tell you, having lived through it here, the mechanisms were very plodding. And this was with federal government operating at record speed, with the possible exception of the vaccine story. Everything else went very, very slowly and very, very difficult. Irene has been articulate on the personal protective equipment crisis. So let's start with Josh and hear your speculations.
I was hoping to start with Bob.
Okay, Bob, go ahead.
All right, Josh, nice one.
Check in.
Look, I think one thing I could address is the private sector and our businesses going to be, could they be a source for this? Because I can tell you again, of these many companies I'm advising, who I told you have taken it so seriously and really impressed me with the job they have done. The question would be going forward, could you say to these businesses, look, this is an issue. And just like you put money into cybersecurity and business continuity planning, is this something that you're going to change your plans about? I don't know the answer to it yet, because we're still, again, right now, my hundreds of emails and phone calls are not about what to do after the pandemic. It's what to do about the holidays and the new variant. But I don't think I would look to the private sector for it. And some of this comes from a conversation, Josh, and I had, which is that I think companies will probably add into their business continuity planning kind of climate change, kind of these pandemics as how their business can respond in a crisis. But I'm not sure that we're going to be able to say to the private sector, you contribute, to a fund that could go to Stanton and other public health schools. I think the business response would be, well, that's what we pay taxes for. We pay taxes because there's a greater good here. And so let's get the government going. Stan, I keep coming back to my idea that getting it from FEMA and not from health circles is worth exploring, because I don't know how to do better with today's model.
I think that's well put on. Just add a couple of quick thoughts. First of all, I think to your point, Bob, business in the world generally has gotten quite concerned about unfunded mandates. So the notion that the government is going to say you must do X or Y and not provide any funding for it, I think awareness about that problem has increased, and people are understandably suspicious about it. I do think we should learn, though, from the pre-purchase program that worked successfully in the case of the vaccines, and recognize that incentives do inspire investment. And so to your point, Sten, I know Yale and the School of Public Health specifically worked on a saliva test and did it in partnership with the NBA, which was innovative and interesting. If you had changed that and said that the federal government actually was going to buy tests from every university that was able to come up with something which met the minimum threshold, you would have inspired, I think the government would have inspired certain behavioral changes if that was in fact the priority. So I don't want to overstate the role of how the incentive system work. I don't think it's going to be successful simply to say, provide more funding. I think it's a little bit incumbent upon the institutions that are looking for the funding to say, okay, here is the problem that I think I can solve. If I am successful solving it, will there in fact be a market or use or funding of that service that I'm providing? And have the institutions be more explicit about how that quick action can actually provide a benefit, and force the government to say, oh my gosh, if you were able to do that, here is the funding that will be provided. And change the dynamic a little bit, because I think it's unrealistic to think that they're just going to provide the money in the hope that you will allocate it wisely and that something will ultimately be available.
Excellent. Bill, Irene, anything to add?
Sten, I have nothing much to add except to say that FEMA isn't a great model either.
We remember Katrina. They've done better since then, but still. Irene, any thoughts?
I don't think so, but what happened once in Arlington, working with the health department, they set up a reserve corps to assist in hurricanes, flooding around the area, giving shots. It consisted of students and retired healthcare professionals and others. But again, that would be an expense, so you may not want to think about that particular model.
Well, it's a little bit of that out of the box thinking that Bob was advocating earlier, so thank you.
Right.
All right, well, we know that there are going to be additional public health crises, and I'm keen to see if each of you has a topic for a future roundtable that you would recommend to us, something that taps into innovation across public and private sectors, health, business, the business of health, so that we can make better progress to tackle this in the future. Today was deliberately fairly broad, but we'd like to do some deep dives in the future. Does anybody have any suggestion for us? And this includes our audience of participants.
I'll go first and then others should jump in. I think there are at least two that interest me. One is thinking about actually the underlying choices that are implicit in some of the discussion that we've had. And I'll just give you an example of what I mean. There was a discussion early on, or a decision early on when COVID arrived, that we were understandably going to prioritize public health and safety, irregardless of the impact to a certain extent on the economy. And that was a decision that was made. There are understandable reasons. I'm not sure, in fact, there was an open discussion around whether, in fact, in the long run, that choice in the extreme to which it was taken was a wise one for many people in terms of their long-term well-being and even their physical health. And if there had been a discussion around that initially, we might have made slightly different decisions, recognizing that there was a huge amount of uncertainty. And that's obviously not me arguing for compromising people's safety. I think it would be an interesting question to say, are there broad choices that should be discussed at an early stage of a pandemic? And I'll just give you one other, going back to this question about why people don't take vaccines. I do believe that a lot of it has to do with agency and a sense of powerlessness. It's not just skepticism about the healthcare system or the historical inequities we discussed. Understanding people's motivations and why they make the decisions that they do, including the power dynamics, I think would also be a question, because I think a lot of the Q&A that we heard was about communication and what are the underlying causes of it.
Thank you. Anybody else?
I think perhaps it may be a little out of the box, but consider contacting a couple of organizations to look at their role in policy. The first one would be the Association of State Department of Healthcare Services. They handle all 55 states, including the territories. The second one would be the National Governors Association. Keep in mind, they again handles all 55 states, states, including 5 territories. So what is their role in working with the governors and working with the state health departments? It could be policy. It could be, how they conduct business. What is their actual role? So I would suggest those 2 organizations just to ask some questions about how can they help.
Thank you. Bob, thoughts?
Yeah, my mind has been going to a couple of things, and one is kind of, since we do live in a centralized, decentralized liberal democracy, how can the central part of that do better? And so you think about the Secretary of HHS, we have a Surgeon General, but we needed a COVID czar. And so Jeff Zients is the one now. He's part of the executive office. And so what should be the proper structure to kind of drive the kind of quicker decisions that CDC is able to make that can help expedite coordination between the FDA and CDC? And is it what we have today, which is you appoint an intermittent czar who's kind of in the EO and kind of rides herd? Is it a different one? And it's in the broader category, Stan, of what if the public health community can help map out, this isn't going to be a once in 100-year thing. We've had 4 or 5 of these in the last 20 years. We've got pretty lucky in this country, until now. But if in fact, with kind of global travel and what's happening with zoonotic infections, this is something that's going to occur a couple times a decade, how would we think differently about the organization to rapidly address some of the things we didn't do well? The whole testing issue, the whole decision-making issue, et cetera. And so I think that would be interesting. The other one I would bring up, and it really it follows up to what Josh said, which I think was really an interesting idea. How do you build incentives? If we need to build up the national stockpile, which to me is the other big issue, and you want to have innovation in the products, better PPE, better tests. The tests are great now. The FDA is finally okaying them. I deal with that every day. I walked into a CVS in New York City the other day, and I thought it was an antigen testing, facility. A month ago, I walked in, I couldn't find one. So how do you kind of do that? And how do incentives play a role in that? I think that's,
Excellent.
we are a private sector commercial country. And how do we do that in a smart way?
Excellent. Thanks, Bob. Last comment, Bill.
Yeah, two things, I think, Sten. Earlier, whenever Lindy brought up communications, both Bob and Josh were talking about messengers at the community level. I think we should ask the question, who are the most effective messengers? They are as important as the messages themselves. These people are faith-based individuals, people working at the community level. I think there's opportunity there. And then the second thing, Sten, is you brought up the business of health. You know, we need to ask ourselves, what is the business of health? And to go back to what Irene spoke about, we need to think about where this fits with social justice, with health equity. If we don't get that right, we're always going to have disruption and trouble.
Excellent. I'm going to turn it over to Lindy for final comments. We started 2 minutes late, so we'll go 2 minutes over. But before I do that, I wanted to thank my colleagues Jeff Sonnenfeld and Howie Foreman for good advice, but especially our alumnus, Dr. Ryan Saidi, who not only suggested this forum, but provided resources from Tibagen Bio, for which he is CEO, to enable the partnership with Tapestry Networks. So thank you most sincerely, especially to Ryan Saidi and his colleagues at Tibagen Bio. So Lindy, your thoughts on summing up in about 4 minutes.
Oh, that's it's going to be a short amount of time. I'm going to keep it to 3, I hope. So I think everyone's kind of touched on it, and it's been a great conversation. And thank you all. I just also want to take this couple of seconds to thank all the panelists for taking their time out of the day to join us. And I think a very timely and very relevant conversation. As Sten noted, we're in the midst of a pandemic still, and whether it's of a concern versus what it will become is still, I think, an open question going forward. So I think the key takeaways that we heard in this fairly broad-ranging discussion, as Sten noted, it really was deliberately broad to go into a number of different topics and then hopefully get a chance to deep dive on some of those topics that many of you have brought up. There's really, I think, a common theme of really the need to integrate business and science and technology better, and the public and private. We're all in our ivory towers. I think that was one of the issues around public health and scientists. I always consider myself a scientist. I'll stick myself in the ivory tower too. How do we cross that and actually get down to communicating better and understanding not just the science, as Josh noted, but how the public thinks in different segments. The public is not one faceless mass. It is a number of different sectors and individuals that think differently. So how do you bring that back from all the academics and folks that work in public health to really understand how communities think and translate some of these issues for this pandemic and maybe others to come? As Bob noted, this is not going to be just once in our lifetime. Likely many of us will encounter this kind of going forward. Another second topic is really this idea of incentives. Everyone has acknowledged the government does have a role. It had a very positive role to play, and there were some very negative also roles that unfortunately came up due to the lack of infrastructure and anticipating some of the issues, as well as the policy, et cetera, that was not quite in place going forward. So how do you create the incentives? How do you create that structure? But it's clear government incentives motivate not just the public sector side and how hospitals and systems work, but also the private sector side. I think, Bob, you noted things like HHS's policy, right, on vaccinating healthcare workers. It's been a question that's come up, right? You've got people who do not accept vaccines in all sectors, including the healthcare sector. So how do you manage that going forward? And how do you create, I think the third one, which is connected to communication and incentives in some ways, is trust. There's been a lack of trust. How do you create that broader set of trust across all the different kinds of entities that have been involved in this pandemic response and going forward? Obviously, we would like collaboration and crossing political boundaries, et cetera. but trust is a very deeply held issue. And as many noted, you need to understand those motivations of what drives people's sense of trust, whether it's agency, as Josh noted, science, or the lack of community representation of people that look like themselves, in the community, whether it's faith-based bill that you noted, or the frontline workers and nurses, et cetera. How do you do that? And I think in the end, some of these incentives are needed to support our future workforce going forward, whether it's the frontline workers and nurses, and not just monetary, but really thinking broadly of them, again, as people, right? Childcare, resources, et cetera. So nurses, teachers, people in public health can do their jobs. And it's not just, about bonuses, it's about supporting them also individually within their communities. So I think that kind of was the top line, and we're over 1 minute, so I'm going to stop there, Sten.
Remarkable, Lindy. Thank you very, very much. We owe this panel to you. Want to thank all the participants from around the world who were able to join us. The others will see this online, the taped version. And Irene, Bill, Josh, Bob, thank you ever so much for doing this for us. We're very grateful to have had your insights, and I learned a lot. Thank you.